My name is Sindhu Johnson. I'm director of the Toronto Scleroderma program. We function out of the University Health Network, that is the Toronto Western Hospital and Mount Sinai Hospital. I'm also an associate professor of medicine at the University of Toronto. I'm originally from Newfoundland, and I came to Toronto in 1998 to study internal medicine. And I quickly learned that I really love the part of medicine where we study multi-system disease. Also, I enjoy getting to know people. So I knew I wanted to devote my career to an area where I would get to know people over time. I did my rheumatology rotation here at Mount Sinai Hospital, and I worked with the late Dr. Peter Lee, who was director of the Scleroderma program at that time. And I learned that scleroderma was sort of the right fit for me. It was a multi-system disease. I got to know people through their life course and got to experience the difficulties, but also the joys in their life. When I thought about what kind of career I wanted to have, not only did I want to help take care of patients, but I also knew I wanted to be a scientist. And so I pursued a PhD in clinical epidemiology. And that's a degree that allowed me to have the skill set to help do science in the realm of patient care. In the mid-1990s, when I was in medical school, one of the most sinister manifestations of scleroderma is what we call renal crisis, where the kidneys shut down, it leads to high blood pressure. It was 100% fatal. And so my mentors would talk about people with scleroderma not surviving a renal crisis. But in the mid-1990s, a new class of blood pressure medications called ACE inhibitors came to the market. And so while I was training, people were no longer dying of renal crisis. Rather, people could live through the crisis and then be supported with dialysis. So that was the first sense of big, important change happening in scleroderma. Now, what I've come to realize 20 years later is that many people who are supported with dialysis, after a few years, their kidneys can wake up and start to function again. And I've had a number of patients come off dialysis altogether and go back to leading normal lives. We really try to practice what we call personalized medicine. The first minutes of an assessment or a consultation with a patient is trying to learn how has scleroderma affected them, because scleroderma can affect people very differently. And so once we have a sense of how scleroderma affects them, we can cater their treatment recommendations to the symptoms that they're experiencing. It can be challenging at times because sometimes we need to ask for extra tests, lung tests or blood work, but as we collect the pieces of the puzzle, it gives us a better picture of what's going on with the patient. I think there are sort of three areas of research. One is better treatment of the complications, the serious complications of scleroderma, where people will continue to live longer. I think we're going to see a conceptual shift in terms of rebooting the computer. Let's reboot this immune system so it stops attacking the body. And the closest we've come to that so far is stem cell transplant. And we've recently seen success with that as well. So I think all these small steps are leading us to a cure. And I like to believe that in my lifetime, we will see a cure for scleroderma.